Well, thank you very much for this kind introduction, and thank you for inviting me to present at this wonderful workshop. I learned a lot, and I will be talking about a topic that has been mentioned several times during the workshop. So with aging, there is an increase in the comorbidity burden, as illustrated in this cross-sectional analysis from the US cohort study. And what is interesting, and it joins actually the conclusion of the study of Lilian Ha, is that the burden of comorbidity seems to be higher in women compared to men. And this could be potentially due to sex differences in the occurrence of comorbidities, in care, sex differences in social economic factor, which can impact access to care. And because with aging there is more comorbidities, there will be more co-medication, of course, and this will increase the risk of having polypharmacy, which is commonly defined as the concurrent use of 5 or more than 5 co-medication. And in HIV medicine, we are talking about non-HIV co-medication that are taken in addition to antiretroviral therapy. So polypharmacy has many deleterious consequences. There is an increased risk of hospitalization, frailty, falls, adverse drug reaction, inappropriate prescribing, and drug-drug interaction between non-HIV drug and between HIV drug and non-HIV drug. But I would like to mention that actually the choice of antiretroviral therapy can modulate the risk of drug-drug interaction. And this is nicely illustrated in this study from the British cohort in Columbia, Canada, where you can see that the reduction in the use of boosted protease inhibitors over the years, and on the same time the increase in the use of unboosted integrase inhibitors, has contributed to reduce the prevalence of drug-drug interaction. And this is also supported by this real-life study where switching from a boosted protease inhibitor to bictegravir or dolutegravir containing regimen will actually reduce the risk of drug-drug interaction with cardiovascular drugs. But you can see that there is, on the other hand, an increase of potential drug-drug interaction with minerals and substances containing divalent cations. So you know that there is a risk of chelation, which will reduce the absorption of integrase inhibitors, but this interaction is easily manageable. You need to actually separate the intake of integrase inhibitors from divalent cations. But I'd like to mention this interesting analysis from the UK POPI cohort, which is a cohort that enrolls individuals that are 50 years old or older, and actually which found that comorbidities tends to occur. And they identified 3 comorbidities clusters: the mental health, the cardiovascular disease, and the metabolic disorders. And if we look at drugs that are used to treat each of these comorbidity cluster, and we look at the potential risk of drug-drug interaction, in this particular study, we used the Liverpool drug-drug interaction website. So you can see that the risk of potential drug-drug interaction for each of these different clusters increases, is much higher with antiretroviral regimen that include boosted antiretrovirals, whereas the risk is much lower for triple drug regimen containing integrase inhibitors, doravirine, rilpivirine, or dual regimen including DTG and 3TC. But if we have seen that with aging there is an increase in comorbidity and related risk of polypharmacy, there is another issue with aging, which is due to physiological changes which can impact drug pharmacokinetic and drug pharmacodynamic. And you have summarized here some of the physiological changes that occur with aging, and which are, for instance, a reduction in the hepatic clearance. This is due to a reduction in the liver mass, a reduction in the blood flow in the liver, and perhaps one of the most relevant change also with aging is a reduction in the renal clearance. So let's see how these physiological changes impact the pharmacokinetic of antiretroviral drugs. And on this slide, you have actually a compilation of clinical studies, but also modeling studies that all indicated that there is an increase in the exposure of antiretroviral drugs with aging. However, the increase is modest and is not considered to require a dose adjustment in absence of severe comorbidities. I like to mention that there are no studies on the effect of frailty on drug pharmacokinetic. And because we are in the era of long-acting antiretrovirals, I like also to show you this study. This is a modeling study where we look at the effect of aging. So we simulated the pharmacokinetic of long-acting cabotegravir and rilpivirine in elderly and younger individuals. And again, there is an increase in the exposure of this agent in elderly individuals, but the increase is quite modest and does not require a dose adjustment. And indeed, you can see that in studies that look at the initiation of several modern antiretroviral drugs in young and elderly individuals, have shown that there was no difference in the proportion of elderly individuals that were virologically suppressed compared to young individuals. And there is also some switch studies, and there are 2 switch studies that are presented at this workshop, where when you have elderly people with HIV that are virologically suppressed and switch to DTG or 3TC or a bictegravir-containing regimen, the efficacy was good and the tolerability was quite good in elderly compared to young individuals. So if the physiological changes with aging don't seem to impact significantly the pharmacokinetic or the response of antiretroviral drug, you have to know that this is not the case for all the co-medication. Indeed, with aging, there are some changes that relate to the affinity of some drug to drug receptor, or there are some impaired homeostatic regulatory processes which will actually increase the sensitivity or the likelihood of having adverse effect for some of the co-medication. So for instance, elderly individuals are more sensitive to adverse anticholinergic effect. This is due to a decrease in the cholinergic receptor in the brain, and drugs with anticholinergic properties can impair cognition, increase the risk of fall or frailty, and are considered to be inappropriate for use in elderly individuals. And I'd like to mention that we developed a list of drugs with anticholinergic properties, which we use to analyze the prescription of elderly individuals in the Swiss HIV courts. So the first observation that we made, but that other courts have seen too, is that anticholinergic drug use is quite common in elderly individuals. And we also found a trend with being on one drug with anticholinergic, at least one drug with anticholinergic properties, and self-reported neurocognitive impairment. And actually, in a second analysis using patients from the NAMACA cohort, those are individuals that undergo comprehensive neuropsychological screening, we could actually confirm the association with the use of drug with anticholinergic properties and motor skill impairment. And our observations were also confirmed by a different court. This is the POPI court, the UK court, which found that recurrent falls were more common in individuals on anticholinergic medication, and that frailty was also more common in individuals on anticholinergic medication. So I'd like to mention this study, which looked at the interrelation between comorbidity, polypharmacy, and anticholinergic sedative drug burden on cognitive ability, perceived cognitive deficit, and frailty. This is a study that was conducted in the Brain Health Now court. This is the Canadian court. And they found that there is an interrelation between all these factors, and the model actually suggests that comorbidity increases polypharmacy, which in turn will increase the risk of having anticholinergic and sedative drugs, which will then impair cognitive ability and the perceived cognitive deficit, and which can exacerbate frailty. So the question is, can a reduction in the use of drugs with anticholinergic and sedative properties prevent and help manage cognitive impairment and frailty in older people with HIV? So I'd like to mention this very interesting study which looked at the effect of reducing the anticholinergic burden on the cognitive performance. And what they found is that when you reduce the anticholinergic burden, there is an improvement in the cognitive performance. So this is a very interesting observation. So I'd like to mention that you can find in the public domain some anticholinergic burden calculator. So you just enter the medication of your patient, and this will allow you to have an anticholinergic burden score and to find out whether you need to take any action to reduce this anticholinergic burden. So here you have represented all the cohort of elderly people with HIV for which there was an analysis of the prevalence of drug anticholinergic medication and inappropriate medication. And you can see that the prevalence of these prescribing errors or the use of anticholinergic medication is quite elevated. So there is definitively room for improvement. So what can we do to limit polypharmacy and prevent prescribing errors? So the very first thing, of course, is to have a complete list of all the medication that people take, including over-the-counter drugs, and to perform regular prescription review. You can actually think about certain questions when reviewing the prescription, and this question, you can find them in the EACTS guideline, and which are, is the medication still indicated in these individuals? So one of the problems is that some medication are prescribed and then carry on, and then we don't know why they are used, but they are just, carry on, and this will increase the risk of polypharmacy. Then I think it's important to review whether there are any inappropriate medication, and for that you can use the BEARS stop-start criteria. You can also find in the EACTS guideline a table with the top drug classes to avoid in elderly people with HIV, and in this list you have a lot of anticholinergic drugs. And of course, important to verify that there is no drug-drug interaction and to favor, when possible, unboosted antiretroviral regimen in order to reduce the risk of drug-drug interaction with non-HIV drug, as we have seen before. And you will find also in the EACTS guideline this novel table of drugs to deprescribe in older people with HIV in presence of certain conditions. So the deprescribing is the planned and supervised process of dose reduction or stopping of medication that may be causing harm or no longer provide benefit. So in the table you will find actually conditions for which deprescribing should be considered, and the problem of maintaining a certain drug, what would be the problem for the long-term use, and then alternative or way on how to deprescribe. So for instance, the opioid should not or should be deprescribed when used for chronic non-cancer pain, as there is a risk of tolerance development due to the opioid use. So I'd like to mention that deprescribing is a complex and time-consuming process because it requires to, have all the comorbidities, first of all, to see whether the drugs are still indicated, but also to be able to detect drug disease interaction, which can occur when a drug can exacerbate an existing condition. It implies to analyze the adverse drug effect to make sure that you're not using a drug to treat an adverse effect of another drug and that you don't have a prescribing cascade. It implies also to analyze drug-drug interaction between HIV, non-HIV, non-HIV, non-HIV drugs. So a lot of resources to consult. It's very time-consuming. So you can find some deprescribing app. There is also the MedSafer website, which allows you to enter co-medication, comorbidities, and you have some recommendation on how to what to deprescribe. But I'd like to mention that we are also in the era of artificial intelligence, and there is starting to see some tools emerging. This is a tool that was done by a Turkish group. It's a prototype, but this tool actually allows to analyze potentially inappropriate drug disease interaction, drug-drug interaction. And interestingly, they actually compared the time needed to analyze the prescription. So you had one arm where the physician and the other arm was the artificial intelligence tool. And the physician took 38 minutes to analyze the prescription, whereas the artificial intelligence tool gave you an estimated list of the issues in 34 seconds. So I think there is need for improvement, for evolving this tool, but it could eventually be helpful to support prescribing. And then I'd like to mention that the care of patients with multimorbidity and polypharmacy is complex and requires a patient-centered, multidisciplinary approach that includes not only a regular review and treatment optimization, considering the risk-benefit analysis, the patient preferences, but also to address modifiable risk factors to maintain physical function and social and psychological health. And just to indicate that optimally, this would require a care model with a multidisciplinary team. So I'd like to cite you as an example, the dedicated HIV geriatric clinic at Chelsea and Westminster Hospital in UK, but there are other models. There will be a presentation later today by Dr. Vera, and there was a model presented here from the Boston HIV geriatric clinic. But in essence, so the multidisciplinary team, including HIV consultant, pharmacist, and geriatrician, work together to perform a comprehensive geriatric assessment and to assess and to address modifiable risk factors for the care of elderly people with HIV. Interventions that are offered to patients include modernization of antiretroviral treatment, deprescribing, and other interventions, including rehabilitation or social care services. And the process includes first a phone consultation or a face-to-face outpatient review by a physician, during which a comprehensive geriatric assessment is performed. And in case of polypharmacy or drug-drug interaction of concern or issue with adherence, an additional consultation is planned with the pharmacist. And after completing this step, the patient case is discussed with the multidisciplinary team. And if the patient presents frailty, a face-to-face meeting is organized with the multidisciplinary team. And in all cases, the recommendation that have been made by the multidisciplinary team are communicated to the patient general practitioner and are also followed up, and there are referrals that are made to a specialist. So in summary, age-related physiological changes do not impact significantly the pharmacokinetic efficacy and tolerability of antiretroviral drug. However, age-related physiological changes can modify the effect of other drugs. Polypharmacy is often unavoidable in elderly. We should avoid unnecessary and inappropriate polypharmacy, and when possible, favor unboosted antiretroviral regimen to reduce drug interaction with co-medication. Multidisciplinary team is needed for the care of older people with HIV to manage HIV, optimize treatment, maintain physical function, support social and psychological health. And I think some point for future research include the impact of frailty on drug pharmacokinetic and drug pharmacodynamic. There are really not many data on this. And the impact of eliminating unnecessary or inappropriate medication on cognitive function, frailty, and quality of life of those aging with HIV. And I think we need also some tools to help with the prescription, and we will see what will be the role of artificial intelligence in this regard. And I'd like to thank all the colleagues and contributors to some of the data that I presented. Of course, the Liverpool Drug-Drug Interaction website, and all the colleagues from the EACTS guidelines and the colleagues from the Swiss HIV Court. And thank you very much for your attention.
Yeah.